Morning, everybody. Morning, everybody.
Is von Emmerich, the channel, the chair.
But this particular article raised very critical questions about how effective, how safe, and how financially effective is this actually. So we have the great benefit with AO Spine, this global community of having fantastic young colleagues who seek not just individual fellowships, but global education through AO Spine. And thank you, Dr. Emmerich, for your stewardship and support of Global Spine Journal. It's fantastic to have a leadership like you here. And 4 of our young fellows were basically tasked to look through their critical and young eyes about how to do and how to use robots. And again, we easily picked 4 critical articles from our journal. Now, when we say critical articles, I think it is a benefit to new technologies to be critically reviewed because that only enhances them. And so that's the spirit with which we have these discussions. It's not saying no to technology, but hopefully making them better and understanding what they can do and where they should go in terms of further evolution. Without much further ado, I'm going to switch to live to Seattle to one of our 4 presenters. Do we have a live picture with Dr. Mohammed Al-Hushaimi? Is Dr. Hushaimi live? Is Dr. Al-Hushaimi live?
Yeah, I'm here, Dr. Chapman.
Good. So I don't see him. Good. So Dr. Al-Hushaimi is one of our fellows. He's originally from Lebanon. He's a neurosurgical colleague, and he's done a phenomenal job. And he has prepared one of the articles, and he wanted to be here but had visa issues, so we really regret not having him here. But it's so nice of you, Mohammed, to see you and for your work on preparing an article. So go ahead, Mohammed.
Okay. Thank you, Dr. Chapman, for the introduction. Thank you all for organizing this very nice meeting and putting all the efforts together. We'll be starting with the first article. Please, can I see my presentation? I don't see it. Do you want me to share my screen here?
Yeah, do you want to go ahead and share your screen? We're not seeing the PowerPoint. Thank you.
Can you all see my screen?
Yes, looks
Alexis Takasumi.
Yeah, so this is the article, the first article we're gonna present. This is an original article published in the Global Spine Journal April 2025, entitled Proficiency Development and Learning Curve in Robot-Assisted Spine Surgery Using the Excelsius GPS System. Experience from a single institution. First author is Shi et al. From New York, Langone Health University. So to begin with a brief introduction, why we study learning curves. With this robotic assisted spine surgery, this expansion of this field, the training and the workflow adoption varies between one institution and the other. Most of the prior learning curve data come from early Mazor systems. Less is known for the Globus Excelsius GPS, so that's why this paper was brought to study this specific robotic system, the Globus Excelsius. Understanding proficiency development helps in planning, staffing, OR efficiency, and safe implementation of these modern enabling technologies. So the main study question from this article was, does the Excelsius GPS has a measurable learning curve, and how fast is the proficiency attained? So the primary hypothesis was that operative efficiency improves with experience using this Excelsius GPS system. The primary end goals from this study were mostly three: total case time, robotic registration and setup time, and screw placement time. The secondary endpoints for this study were fluoroscopy dose, complications, and returns to the OR. So this study design was majorly a retrospective cohort from a single high-volume academic institution between the years 2021-2022. The cases were mostly navigated robotic assisted spine surgeries with Excelsius by one senior attending surgeon and a fellow that assisted. The data resources were mostly the electronic medical records, robotic software planning, and also the intra-op 3D imaging that the patient has. And most of the analyses were descriptive with two sample t-tests and a cutoff p-value less than 0.05. So these are the primary demographics from the study. Most number of patients, 95 to 97, to different reports in the paper in the table showing 97. The mean age of the patient was around 66 years, BMI 31. Total screws 541. Most of the screws were in the lumbar area, 492, fewer in the thoracic, and very few S2 AI screws. It included mostly one single level or two level fusions. And as I mentioned, the mean total operative time was 129 minutes. The registration time was around 27.7 minutes, and screw placement with closure around 94 minutes, and the total fluoro dose was 58.6 gray. This is the same table with the demographic here. The reported complications were around 8, with one of which required operative management, which was a complication including an epidural hematoma. The cases, as I mentioned, were divided between single and two-level fusion, and that will be shown later during the results and the subgroup analysis. Beginning with the results, these are the learning curves for all cases together, the total time versus the number of cases. So as you note here, there is a total case time dropped significantly after this point here, which was around 14 cases. Similar trend for the screw placement time. So the screw placement time started to improve after 13 cases here. No significant change across the cutoff in the registration and the setup time for all the cases, and similar trend, one or two level fusions will be seen later on. So this is the area that did not improve when trying to register these and work with these robotic systems. This is here the subgroup analysis for single level fusions. A similar trend, the improvement started after cases 9. So between case and 9 and 10, the total time of the case started to drop down. no improvement, no significant improvement in the robot registration time for this group. Also, the screw placement time improved after around cases 19 to 20 here. Similar trends for two-level fusions. Also, the improvement around mid of the cases, which was around 15. So as I mentioned, similar trend for all this. We'll skip this time here, and we'll go to the discussion. So when we reviewed the literature regarding these robotic systems, around 21 studies had discussed this topic previously. Most of these studies either evaluated single surgeon or multiple pooled surgeon experience. Very few involved trainees and fellows, and this is very important here because of the learning curve should include those people assisting in these cases. 18 out of 21 studies reported a learning curve. Only 3 studies did not report a learning curve, and most of these studies has a smaller sample size, except for one study was done on a large measure, a spine study with around 112 patients that did not show a significant learning curve. For these types of studies, the data was reported in 2 different methods. Some studies, they commonly refer to the procedure as a single case without going into the specific number of screws. Other, they report cases as screw numbers and how the improvement after a specific number of screws. One study reported that there is a plateau at around 20 cases for the robotic usage. And what's interesting and why the study was mentioned, that only 3 studies were specifically addressing the Excelsius GPS system with very small sample size. So this is why the study was confirmed. Another paper by Sadiq et al. Reported that accuracy improved in terms about the screw tail placement after around 30 screws, but the timing and the robot user's time did not improve. Another study by Faid et al. Included 20 patients, 2 attendings per case. There was a slight trend toward fewer breaches later on, but most of these studies were underpowered and very little sample size. A third important study reported on the operative time, that the operative time decreased about 4 minutes per case, and the strongest drop was around 10 cases. So similar to what we have shown in this previous article. Going into the critique and the limitation of such study. So as you all know, these studies are retrospective in nature, and they have being a retrospective study by itself is a major limitation. The non-randomization for the cases, so it was not reported how the patients were chosen whether to go for like fluoroscopic base or robotic. So it was like a surgeon preference to use the robot or not, or the surgeon's expertise with the robot. This study was based on a single attending surgeon study, limiting its generalizability compared to the other studies, and of course the need for long-term outcome tracking for such cases with these modern technologies. The take-home message from this article was that there is a clear learning curve, proficiency of around 14 cases. What improved, obviously, as from the curves I showed earlier, was the total operative time and also the screw placement time. But what did not improve was the robot registration time. And this is here where we lag, and the improvement should be done. So these robots should improve. This time for the registration should be shorter and shorter. We should try to make them more efficient, saving the time for the operation. Why does this study matter? It adds to the limited Excelsius GPS learning literature and supports integrating the robotic assisted spine surgery into practice and training, and improves this efficiency and potentially the outcomes. thank you all for hearing. These are few pictures from our OR here in Swedish. This is Dr. Skuyen. He's our robotic guy. He's a colleague of us. And thank you so much.
So I'll ask Dr. Wang to come up to the podium for a second. But as he's coming up, Mohammed, you've
Sure.
worked both with Excelsius and Mazor.
Yeah.
How has your exposure to robotics been? What is your first-hand person report?
Regarding the two systems, so both system has their limitations in regard to the framework that connects to the table. The registration time is still too long. So I was discussing this yesterday. We had a complicated case with the patient with infection with an ankylosed spine. It was a bit complicated case, but the issue with the robot was the registration. We still lag behind. So if we do these cases open, we still can achieve better operative time. But the screw accuracy is better, but still, I don't see any improvement comparing these two systems. We still need to work on them. We're like still in the Nokia stage of these robots, so we did not reach these developments yet.
Great answer. Dr. Wang, we had a terrific session this morning with our AO Spine Youth Club. There's an echo here, sorry. And how do we handle integration of revolutionary new techniques in an AO Spine curriculum to make it more seamless and more natural while not forgetting the roots of our core competencies?
Yeah, so Jens, that's a great question. I think it's important just to make people aware of it, because I think we, as some of the older surgeons, will look at it in the context of how this is new technology. I think from a younger surgeon perspective, this is not new technology. This is what they're dealing with in their early careers. And so I would encourage them to take it to the next level. I would agree with Mohammed, great presentation. I would agree with his assessment that right now, I mean, a lot of people will sit there and say, what is the value of doing it? Because it sounds like we don't learn as far as the setup time. And I don't need this maybe to put in screws, but I think I would challenge the younger generation to give us the application that will take it to the next level. I remember the same thing with navigation. We first got navigation. I was like, I don't need that to put in screws. I still don't need it to put in screws. It's kind of nice to have it to put in screws. But the fact that it went to the next level, and now navigation is an integral part of what I do, I want to see that in robotics. And I don't know if us older guys are going to do that, but I would challenge the younger generation to find that next step in the usage of the robotics.
Great. In the interest of time, thank you again, Mohammed. And I'll need to have your help, please, to switch to the presentation. Dr. Casey Spellman is also one of our fellows, a neurosurgical colleague who's a trainee from the University of Michigan, a neurosurgical program of the first order. And Mohammed, stay with us if you have any questions, fire away. But Casey Spellman is going to talk about distribution of robotics. And yesterday in a session, in an opening session, I asked the question, how many in the United Arab Emirates have robots in their 2 centers? So let's look at how's in North America. Casey, thanks for coming all the way over here from Seattle.
Yes. Good morning, everyone. Dr. Chapman, thank you for the introduction. My name is Casey Spinelli. I'm a PGY5 neurosurgery resident in Michigan, currently completing an enfolded complex spine fellowship with Dr. Chapman. So let's get to this article. So today I'm going to discuss geographic and socioeconomic disparities in robotic spine surgery access in the continental United States, a cross-sectional ecological analysis. This was a paper put out with senior authors from Jefferson and Rothman and Alex McCarroll paper, other contributors from SUNY Downstate and Cleveland Clinic. It was published in Global Spine Journal very recently. And so why talk about this topic, right? Robotic assisted spine surgery claims improved pedicle screw accuracy. They claim reduced radiation exposure for the surgeon and the patient. They claim faster operations and great marketing for surgeons and for hospitals. So, but adoption has been limited, right? And why is this? We see 2 major manufacturers between Globus and Medtronic. They dominate the US market. And so the premise of this study, as technology diffuses, where is it available? And are there geographic or socioeconomic disparities in access to this technology? And so the authors initially hypothesized that robotic spine surgeons cluster in urban areas and that they would be associated with academic centers, leaving rural or more disadvantaged communities with less access to this robotic spine care. So how did they do this? This is a cross-sectional ecological analysis. So as an ecological study, they looked at county-level data regarding socioeconomic covariates of their patients. They didn't look at individual patient data for these things. They looked at provider directories from Globus and Medtronic to identify 91 robotic spine surgeons in the continental United States. Hospital teaching status was assessed from the American Hospital Association survey as major, minor, or non-teaching hospitals. They used geospatial mapping to measure the travel distance from the center of each county to the nearest available robotic spine surgeon that they identified. And then they used a variety of socioeconomic covariates, including this area deprivation index, to look at some of these things. So some strengths of these methods were using publicly available data, so no IRB was needed. Some limitations of this is they relied entirely on the two manufacturers' marketing directories, potentially undercounting spine surgeons using other systems, though there's much fewer of that. So what did they find? They identified 91 robotic spine surgeons in the United States. They identified that the majority of these were actually associated with non-teaching hospitals, over 50%, with minor teaching next, and major teaching hospitals only accounting for 11% of the robotic spine surgeons. So that was definitely different than what the authors hypothesized when they set out to write this paper. They showed that they concentrated in community and private hospitals, and then they identified these geographic hotspots, so the shortest travel distance from the counties to the surgeons in the Northeast and Southeast United States. So in the hotspots, the median travel distance from the center of a county to the surgeon was around 57 miles. And in a cold spot, the median travel distance was around 220 miles. Spatial clustering confirmed significant hotspots in urban corridors and cold spots nearly everywhere else, especially the Midwest, Mountain West, and rural areas. There we go. So this top figure here, just each dot represents a robotic spine surgeon, kind of a county map. This next picture down is showing the average travel distance from the center of the counties to the surgeons. And this is probably the best graphic from the paper. It's really easy just to kind of take one look at it and identify the hot spots and cold spots with regards to access to this robotic spine surgery. So looking at the socioeconomic covariates, some predictors of access, hotspots had higher disability prevalence. They had a lack of insurance and an older median age, but they had a lower deprivation index and lower Hispanic representation. So the authors concluded that access is in fact unequal. It was concentrated in the Northeast and the Southeast. They concluded that adoption was more driven by market forces rather than academic centers. They discussed non-teaching hospitals adopting robotics to remain competitive and to attract patients. They discussed the high upfront and per case costs of this technology can create financial barriers, especially where reimbursement is lower. The authors call for regional grants, public-private partnerships, and bundled payments to improve equity and access to this technology. And they acknowledge that the cost effectiveness of this technology remains unproven. So some critique and praise for this paper. I thought it was solid for what it wanted to do in terms of looking at, geographic access to the robot. I think if we're gonna journal club style critique it, we can talk about this ecological fallacy where county level associations aren't necessarily the same as individual patient access to this. And obviously they didn't include clinical outcome data here. So does access to this really mean better care? Who knows? This paper doesn't comment on that. So then this discussion, these are my thoughts, not really mentioned in the paper, but I think kind of germane to this conversation are 3 points, right? The value proposition of these robots. Is the cost justified when outcomes are compared to other techniques? And if so, at what threshold? What's the ideal use case, right? Some of us might think of it for big, long deformity cases, but the last paper we discussed was mostly 1 and 2 level fusion cases, right? Is this better than using navigation without the robot? I think another comment based on the findings of this paper is what's the role in a non-teaching institution, right? Is it patient capture or is it surgeon retention in some ways, right? As we're pushing a lot of these smaller cases to our surgery centers where our margin is much smaller and there's like a smaller reimbursement there, right? Can a community hospital having this technology keep that case and that surgeon doing this case at their hospital, right? Where they're going to get paid more for it and they can afford it. And then another, future directions, where is this going to go, right? Because I think as robotic autonomy increases, right, the device companies are going to have greater liability, right? If the robot is there autonomously putting in screws, they don't want to get to that point because they don't want the liability of that. So what is the middle ground? Where are we going to go between now and there? And so I think some discussion points for that. So anyway, thank you guys. These are my co-residents back home in Michigan. Thank you very much.
I'll stay up here, ask our Congress Chair, Dr. Abolfotouh, to come up here and introduce the next two fellows. But one question to you is, can I take the prerogative of going back and using your mouse, show us where Michigan is and how is Michigan doing in terms of robotics?
It's tough to say. In the group that I'm currently training with, we really don't use it that much. There's another private group in town with a very busy surgeon who uses one of the robots for many single level or 2-level MIST lifts. So it's kind of a mixed bag. I know they like their experience with it. They think their workflow has gotten fairly efficient. The group that I work with, we more use nav without the robot. So.
And Michigan is a very competitive, actually very large and very diverse state. So has this, from what you can see on the ground level, appealed to patients so much that they would go travel big distances to get to a center that has a robot? Is the public perception of Michigan such that this is a competitive therapeutic advantage for their behalf?
That's a great question because obviously it's our competition that's using this. And so they want to seem very busy with it, right? But I have no idea what their volume really is or if they're gaining market share from the robot. But.
Great point. Thank you. And I'll ask our Congress chair, who's done such a phenomenal job, can you help us get the next slide up, to maybe comment on my observation that from what I saw from the audience response yesterday, there are only 2 centers in the UAE who have robots so far. Is this a competitive advantage? Is this something that is a near and dear progress for you? And then I'll ask you to introduce your 2 resident presenters.
Sure. Well, thank you very much. First of all, beautiful presentation so far. I think, yes, technology is making its way in the UAE. We have more navigation than robotics around the city. I still think the number one reason for surgeons buying robots in their hostels nowadays in the UAE is that because the next hostel did buy a robot and they need to have that competitive edge as well. We still, as presented earlier today by the earlier presenters, that there is still no evidence that it adds to the outcome of patients. And I think over the coming couple of years, we're going to have more adoption in the UAE of having more robotic surgeries, obviously. But till we have that paper that tells us that this improves the outcome, I don't think we're going to see that huge surge in the number of robots that are being adopted. So for the sake of time, I'm going to move ahead and introduce our next presenter. Our next presenter is Dr. Mohammed Al-Hassan. He's an orthopedic resident at the orthopedics department at Medcare Hospital in Dubai. And Mohammed will be talking about to us, presenting a paper on the value of navigation in adolescent idiopathic scoliosis. Mohammed.
Thank you, Dr. Sameh, for the great introduction. And good morning, everyone, and good evening in Seattle. I just want to start my presentation by saying when I was assigned to this presentation, as a younger generation surgeon, I was actually so impressed about the navigation and I had a lot of expectation. But when I read this paper, I came in shock. I'm like, okay, this is what we're dealing with. So for this talk, we need to talk about the computer-assisted navigation does not improve the outcome in posterior fusion for adolescent idiopathic scoliosis. This is an article that was published in the Global Spinal Journal by Senia and his colleagues. So they're asking a very fundamental question in this paper that we're going to target together. But mainly, are we paying premium costs for every single case just to feel better about our x-rays? So to answer this question, the data showed there is an increased adoption to the usage of the navigation up to 6 times since the year 2016. It went from 2% or 1.7% to 11.7%. That's in 4 years, which is a massive massive surge. So the authors pulled out data for almost 29,000 patients to see if this shift is actually helping anyone. And that was extracted from the National Readmission Database from the years 2016 to the year 2019. And this data source represents almost 62% of the US population. The cohort selection for the study was an inclusion of the adolescent idiopathic scoliosis using the ICD-10 code. And the procedure that was done was the posterior fusion, and the timing for it was allowing 30 days follow-up. However, the exclusion criteria for the study was the robotic screw placement just to isolate the navigation effects. So the research gap that the authors found that although the literature confirms that the navigation places a screw more and more accurately, we still don't have evidence that shows superiority to the navigation in value and cost. So our objective was to compare the efficacy and the safety of using the navigation versus the conventional pedicle screw. The authors match over 2,000 navigation surgery patients against 27,000 conventional patients, making it close to apple comparison. You can really, this is the only thing that you can get from a retrospective cohort like this. And you know, that makes the data very much hard to brush aside, because we expect, and I think we all expect, that the navigation would be superior to the conventional. And that's the whole pitch of the navigation system when it was introduced. However, it shows a balanced comparison when it comes to demographic and other comorbidities. But the safety paradox shows that there is an increase of the navigation surgical complications. And it shows that there is an associated odds ratio of 2.23 for the surgical complication, and a p-value was less than 0.01. And that is a very small but highly significant value. Let's just be clear about the driving factor for this complication was mainly the bleeding. It wasn't the neurovascular complication, it was bleeding. And the odds of the patients needing blood transfusion were nearly 2.5 times higher in the navigation group. But why was this? What does it has any connection? It has to be the time. The study have showed that there is more study found that setting up the registration system add almost 41 minutes extra to each case. And the 41 minutes in a deformity surgery, well, you know, time is blood. And the more time you spend, the more blood that you're going to lose. And Tang and his group actually quantified every single additional minute in the OR for the posterior fusion surgeries and showed that every minute in the OR increased the significance of losing the blood by almost 1.5%. So that's, at the end of the day, indicates a higher transfusion rate. So that brings the question, which is really the navigation accurate? And are we benefiting from this? Or are we just getting a prettier CT, post-operative CT images? Well, the authors conclude that there was no significant improvement in the length of stay or the readmission despite the high-tech intervention. In both conventional and the navigation patient, there was a same 4 days length of stay, and there was no difference in the discharge disposition. And there was also no 30-day readmission or reoperation rate. So there was no difference at all. So that means the radiographic accuracy does not equal to the clinical benefit. So why don't a perfect screw lead to a perfect outcome? So we all agree that the navigation would place us a far better screw on our CT, but the screw malposition is very common. It's almost 15%, but it's rarely symptomatic. And the literature shows that less than 0.5% of the cases have complication related to misplacement. But the trade-off to this, that if we are preventing an asymptomatic malposition, there is no, and that offers no measurable recovery benefit. However, if we want to pursue an actual radiographic perfection, that will come with a high cost of a longer operative time, and increased blood loss, and higher financial charges. So literature again confirms that although we're improving the placement of the screw, we still don't see any clinical relevancy, and the screw malposition rarely leads to any clinical consequences, almost less than 0.5% of the cases. So in conclusion, we're solving just a radiographic problem. We're not fixing a clinical problem per se, but we're doing this at a premium cost. And that translates in numbers from the database. It shows that the conventional surgeries were almost $77,000 cheaper than using the navigation. And again, we're just using a premium $77,000 difference, but we're only just increasing the length of the length of the procedure with no difference in readmission rate or any difference in any clinical scenario. So again, if we look at a common summary of the whole conventional versus navigation, it just shows that we have more expenses when it comes to navigation with a higher risk of surgical complication with no differences to reoperation and readmission. So is it safe for us to go and do these surgeries with the navigation and risk the patient having a perfect screw, but at the same time having more blood loss? Would that make our case better with using the navigation? That's going to be the real question that we need to address. It really puts us the responsibility back on us as surgeons to ask, is this tool doing the right job? Or is it just satisfying our ego to see a great CT scan? So this study has a quite limitation, and the retrospective design of the surgery is one of the limitations to this study. And there was a few missing clinical variables. There was no data on cup angle or specific number of the level fused throughout the study. And the short follow-up duration was less than 1 year for the long-term revisions and wasn't captured in this data. So to conclude, the last thought that I want you guys to understand that at the end of the day, we have a $77,000 extra to the hospital bill and an increased risk for a patient blood loss, all without preventing a single trip to the operating room. But why is this rapidly becoming the standard of care? Something that the authors mentioned that we need to also dig deep into and have more studies in, because the current data does not show any support of the routine use of the navigation in the posterior fusion of AIS. However, it just increases the financial burden and increases the morbidity without demonstrable improvement. So the final recommendation is the surgeons and the hospital should weigh the specific need for an accuracy against the proven risk increased if the operative time and blood loss. Thank you so much.
Thank you, Mohammed. Great talk. First of all, do you use navigation routinely now in your spine exposure so far?
So in my spine exposure so far, we do see navigation a lot. We do see most of our surgeons using the navigation. And as I said, in the beginning of somebody who's just starting his training, to me, navigation seemed like, okay, this is the safest option. This is the way to go. And I'm seeing great results with my attendings. But at the same time, looking at studies like this makes you open your eyes more on what are the next level of technology is going to provide for us. And do we need to be aware of that and be careful when we're using it? And do we go back to our old ways, or do we stick and actually increase that learning curve? Because still, there's always 12% of surgeons are using the navigation. Is that percentage like climbed up to 50% per se? Let's say that would make any difference? That's what I have to know.
Without exposing you too much, did you get trained on open or freehand techniques first and then do nav, or did you have a dry lab run first? How was your immersion to the various techniques, traditional versus new?
So in the beginning, I had a rotation in neurosurgery where we saw a couple of open cases. And I still haven't gotten to my full spine rotation to see it, but I have seen my colleagues actively participating in navigation. And I think my colleague, Dr. Hilmi, will give you more insights on what they do exactly with the navigation.
Great presentation. Thank you so much. Really good to have you here. Thanks for doing this on short notice. Quick comment and a question to Dr. Ashraf Al-Naga. He's an attending physician at the world famous University of California, San Francisco. He's mainly a trauma surgeon. He was our chair of our 11th Spine Trauma Symposium. When I saw this paper, I was worried about the following thing. I know you don't do deformities, but the more you get away from your registration site, the more inaccuracies come in. As a trauma surgeon, you alluded to it yesterday in your excellent robotics and sacral fracture fixation talk. The second question is, could it be that maybe with the enablement of navigation, surgeons are a little bit more risk-taking, like in the concavity with very dysplastic thin pedicles, that they do screws that the conventional surgeons would probably not risk to do? So registration accuracy and the diligence of that with re-registration, and then more risk-taking behavior because you feel enabled by technology.
Yeah, no, I think, well, first, it's been an incredible journal club. And I think the question that's always on all of our minds, especially because I'm at an institution where we don't have a robot, it's, and we're always considering it, is it's a value proposition, right? With regards to the use of navigation in trauma, I think it needs to be very thoughtful, because unlike a rigid deformity case, now in the setting of trauma, you have, a more mobile spine. I think we can do it, and we can do it safely, but you would say maybe change your workflow a little bit, where you have fiduciaries on both sides of the fracture in order to reduce the effects of that motion in between. And the second question?
More risk-taking behavior because you feel that your virtual reality screen shows you something that enables you to do something. There's a great practical application for spine trauma surgeons, cervical pedicle screws. And maybe Jeff can comment on that also. Between C3 and C6, there's very little reason to do those, but now we have a technology that shows us the pedicles, at least on the screen, and we may do that. So what are your thoughts in terms of risk-taking behavior changing due to technology?
Yeah, so I mean, it's a question of what are the benefits compared to what are the additional risks. I think with the deformity scenario, so while you may not want to do that, place screws on the concavity using the traditional approaches, the navigation may give you additional information. So now you have more information, so you're not taking as big of a risk, so it does. The question is, are you taking an increased risk, or now have you mitigated that risk and now you're able to take that action a little bit more safely? With regards to cervical pedicle screws in the setting of trauma, right now I would be pretty hesitant to do so, because those right now lateral mass screws in my hands, they're probably the safest screws I can place with very little need for additional imaging. I think if I run into a scenario in which we need the additional biomechanical strength for the fixation, or if I see that I'm trending towards having more hardware failures because of lateral mass screw pullouts, that might, have me consider it. But right now I'm not solving there's no problem I'm currently solving by changing my instrumentation technique.
I want to thank you again for your leadership in spine trauma, and it's great to have you here. And I'll ask our course chairman, Sameh, to come up here and introduce our last speaker. I want to again recognize the great support by AO Spine and the phenomenal organization. Thank you so much for your great international connectivity. Our last speaker, and great hospitality here, great organization, and I think hopefully very compelling topics about the insertion of new technologies.
Well, thank you, Jens, and I echo what you said earlier, and thank you also to the Seattle Science Foundation for working on this and all the hard work they did over the past couple of days to make this happen as well. Now we're going to jump back on the topic of robotics again, moving away from navigation to robotics, and our last presenter is going to be Dr. Helmy Abdelbari. Helmy is an orthopedic resident at Medcare Hospital as well, and he's going to be talking about the complications with robotic surgery, with the newer generations of robotic surgery. Helmy.
Thank you, Dr. Sameh, for the kind introduction. Good morning, everyone. Good evening, Seattle. I'm Dr. Helmy Abdelbari, an orthopedic surgery resident. I'm going to be presenting this paper titled Complications Have Not Improved with Newer Generation Robots, published by Farivar et al. At the Global Spine Journal. So we know from the literature that pedicle screw malpositions with a freehand technique tend to be reported in up to 8 to 50% in the literature. And so the robotic systems are marketed in a way to show that improved accuracy. They're marketed to reduce surgeon fatigue and enhance the minimally invasive workflow. And I guess the question here is, does this improved radiographic accuracy necessarily correlate to improved clinical benefits and improved clinical safety? And so the study objective and the primary aim of this paper was to focus on the robot attributable complications specifically, and not necessarily focus on the general surgical morbidities that follow any operation. And they did this to try and determine whether the new generation robotic upgrades improved the safety, the clinical outcomes, and improved the robot complication rates. When it comes to the methods, the paper followed the retrospective cohort design. They collected data between 2019 and 2022 from the Cedars-Sinai Medical Center in Los Angeles, California. The patients were under the care of 14 spine surgeons, of whom were orthopedic and neurosurgeons. The inclusion criteria involved all robot-assisted spine cases using the Mazor X Stealth Edition by Medtronic. The exclusion criteria involved isolated SI joint fusions. Now, this was descriptive statistics. There was no comparative group in the study. So yeah, the total number of patients in this paper was 264. 54% of them were female, and the average age was 63 years. Some of the more common preoperative diagnosis and I guess the indications for the procedures was spondylolisthesis, accounting for up to 30% of the cases, degenerative scoliosis with 20%, and then degenerative disc disease for almost 17%. 50% of the surgeries were open, and the other 50% was through a minimally invasive approach. The average instrumented levels per patient was 4.2, and almost 25% of the patients had pelvic fixation, with 72% of them needing interbody fusion. So we come to the results of this study, and so the results were the following: the robot-related complications of this paper was 2.2%, that accounted to a total of 6 patients, with the reoperation rate being 1.5%, taking into account 4 patients as well. And so 3 of these patients had a temporary nerve root injury that required reoperation. 1 patient actually had a permanent motor deficit from tap damage to the L1, L2 nerve roots. Another patient had a dural tear that required laminectomy and repair intraoperatively. And finally, 1 patient had a sensory L5 nerve root injury from the drill. Now, we compare the study with the results to other more published studies about the similar robots, relatively in a similar time frame. And we don't see a clear downward trend. The older generation robots roughly had similar rates, complication and reoperation rates, and our study is not different. So in a way, we could say that radiographic accuracy does not necessarily correlate to clinical safety. While the newer robots improve the planning and the trajectory precision, they do not necessarily eliminate the navigation-related human errors. The complications mainly stem from reference frame placements. And so, but it's in fact 50% of the complications in this paper were due to reference frame errors. And so by the definition, this is a type of navigation failure where the reference frame is unintentionally moved during surgery. The typical mechanisms that the author believed to cause this was due to either a reference frame that's placed too far from the operative level, a movement of the spinous process clamps, or maybe it was due to pelvic reference frame inaccuracies, specifically seen in long constructs. One of the examples that the authors mentioned of a complication is this one of a 76-year-old male patient that presented with worsening thoracic back pain. They did a left lateral T12 to L1 discectomy with a T10 to L3 posterior spinal fusion. Now, if you look at the diagrams, the diagram labeled A was for the T10 level. On the diagram labeled B was for the T11 level. And they both had basically right medial pedicle wall breach with a left lateralized screw. And I guess the key point here is that the distant reference frame that was used in this long construct led to this malposition risk. And so at the end of the day, this patient had to or required the revision surgery to adjust the screw and replace it. The authors recommended a few points to tackle this issue with the reference frame. They emphasize using pedicle screw-based reference frames or extremely rigid bone mounts as much as possible and avoiding clamps. Placing the reference frame as close to the level of the surgery as possible is very important, and they emphasize the chicken foot check. This is where you perform frequent accuracy checks, verify the trajectory against the landmarks before every bone preparation. And when it comes to bone preparation, using high-speed burrs and any tools that would minimize the force and the vertebral movement. So just like any other study, this paper had its own limitations. It was retrospective in design. It didn't have a comparative known robot group, which made it purely descriptive statistics. And some of the other variables were not followed, including the bone preparation technique and the general workflows of each surgeon and the frequency of their accuracy checks. And so as a conclusion, again, the robot-related complication rates was 2.2% with a reoperation of 1.5%. This wasn't an improvement from the older generation robots, and the authors believe that this was primarily due to navigation and reference frame errors. At the end of the day, the authors believe robots are a tool, not a substitute for surgical vigilance. And I think this is something that Dr. Chapman touched on yesterday with his papers, with his presentations. And but yeah, at the end of the day, more robust, prospective, randomized control trials are required to validate the clinical benefit here of the newer generation spinal robots. Thank you very much.
Again, a big shout out for our presenters. It's so cool to have the young generation that's going to take care of us as we're aging, provide such great reviews that are critical but meant to improve these exciting new technologies. I have a question for you, undeniably very intelligent, sophisticated young man. Would you feel comfortable if you came to Seattle, you've never been there before, to sit in a navigated auto drive cab? I'm not going to mention any companies there, from any of the major software companies. Would you entrust yourself to a driverless vehicle at the rental shop and find your way into the inner city of Seattle where our hospital is?
Wow. I don't know about that. I will try to. I don't know how tough the drivers are in Seattle, but it would definitely. I would have to look at the data to see if the drivers are furious. They definitely are furious here in Dubai. I don't know if you've noticed that.
That is robotics. You as a young surgeon, are you excited to get this technique into your armamentarium, or do you want to learn the craft first? The paraphrasing of the previous question to your colleague. Do you want to learn traditional techniques first? Are you super excited to jump on ships so you have this badge of latest and greatest technology under your helm? So,
well, definitely have to learn the craft first, and with the freehand techniques. This is, I guess, an absolute necessity for any surgeon nowadays. But I am very much excited to see what robots have to do or what they have to show in the future. I think, technology is always something that we could be very wary of, but at the same time, we have to try and see how things move and how things progress in medical care and surgeries as well. So it's something that I look forward to in spine and outside of spine as well. I'm still an orthopedic surgery resident, but it's something that's always something interesting to look forward to.
great answer. Thank you again. I'll invite Dr. Sameh and Jeff to come up to the podium. Thank you so much. Great job. So, yeah. Okay, we can sit on the chair and make ourselves more comfortable. And I'll sit there. Good. So, outstanding technology. So, integrating robotics, what does this quick review leave you with? Is this something that you can't wait to get into your hands here, or do you want to wait and see for the next generation 3 or 4?
Well, I'm always excited about new technology, and I think it adds a lot, not just in robotic surgery, but technology in general in spine surgery. Do I think that we are there with robotics nowadays and solves every single problem that we have in the OR? Definitely not. I'm pretty sure in the coming future, we'll have better generation of robots that can solve a lot of problems that we have. But I also agree with the fact that training nowadays need to involve robotic surgery as well. It's not just about getting them to do freehand and MIS screws, then robotic surgery. as we saw earlier today, everything has a learning curve. So it's very important to involve that in our training for the residents today and the fellows, because in the near future, that's probably what they're going to be using, and no one is going to be putting a freehand screw anymore. So I think that's very important to be integrated nowadays.
Jeff, LA is a hyper-competitive market with 3 major academic systems and a larger number of very eloquent, outspoken, social media savvy private practice groups. How much is the motivation of covering this new product technology motivation to have robotics and integrating that in your care advertisement versus a true clinical need that's being met?
Yeah, and so that's a great question. I think right now it's a lot about marketing, and it works. So that's the issue, right? We can sit there and say it's all about marketing and people like to hear about robots, but the fact of the matter is patients want that. I've had patients come to me saying they want me to do the surgery because I got a robot and the colleague didn't. So it's kind of sad that it is more of a marketing tool right now, but it's also sadder that it works with patients. And so it's like goes beyond just marketing. It in the patients, they want that. And the other thing that, if I may answer the kind of the question that you asked, Sameh, because the answer I had surprised me, because I just listened to all these articles, and it basically says, I'm not going to have better outcomes. There's not going to be a huge benefit for using the robotics and navigation. But as I sat there listening to these talks, I said to myself, but how many times have you're in the operating room and you feel better? You feel more confident. The residents feel better. I feel as a teacher, I'm watching them put screws in and I can see, and I think to myself, if I didn't have the navigation, I'm looking at them from across the table, judging their hand, but now I can look at the screen and judge it. So is it a better teaching tool? So I guess I'm watching these articles, which great selection articles, and the obvious conclusion is to sit there and say it doesn't really make that much of a difference. It's not cost effective. It's not changing outcomes. But that literature doesn't capture the real world situation with us sitting there and the confidence you have. It's hard to articulate it, but I'm sat there and I'm surprising myself by answering it this way. But there's a benefit that's psychological, that just takes a load off your mind. We talked yesterday about mental battles and things like that. It actually may prolong someone's mental capacity because it takes a lot of stress. So that's something that can't be measured. It's certainly not going to be measured in dollars in terms of operative time. But when you start to use it, and we use it, sometimes you just feel better about it. And what's wrong with that? I guess I was listening to some of the articles and I sat there saying, like, I think insurance companies are going to come and say, we're not going to pay extra for that. You're not going to get more money for it. But what about us as surgeons? What about if it makes our life easier? What if it takes some stress off of us? What if it helps the learners, our residents and fellows, learn better, quicker? Where's the value in that? And so in some ways, I want to push it. And I still want to challenge the young surgeons to find that next level where we can justify it in patient outcomes, in cost effectiveness, as well as in the psychological aspects of things. Sorry for the long-winded answer.
Can I add one comment? I think if we keep waiting for the 3rd and 4th generation robot, it's very important for us to try what's out there today and give feedback to the companies, give feedback to the industry, because otherwise they're not going to evolve. We're not going to see that 3rd and 4th generation. We're probably going to end up with the same problems because we're not giving any feedback and we're staying away from using technology, awaiting something magical to come that's better than what's available now today. So it's very important to get integrated with that if we believe in technology, and our feedback is the thing that's going to end up coming with that 3rd and 4th generation robot as well.
We're coming to a close, but I have 2 final, relatively rapid fire questions. One very practical one for Jeff. So one premise of robotics is to allow for more targeted percutaneous fixation from the back. That's a tangible present day potential advantage. I have struggled with open procedures where we've had this frame shift that one of the speakers showed more than once. And I get pretty frustrated when registrations and re-registrations accumulate. So how much is this a practical benefit in terms of percutaneous versus open surgeries to actually have a robot? Is there one?
That was the exact example in my mind that I was thinking about as I was sitting there saying, the studies are not capturing this. Like I can look at an X-ray post-operatively. I can tell which ones I used a robot, which one I didn't. Everything's symmetrical. The screws are perfectly placed. I can also tell you I've done percutaneous screws with navigation without the robot where the heads of the screws are off and it's so hard to connect it. When you do it the robot, you line up the screws, you put the rod in, it's so much easier. And so that's the benefit that these studies are not measuring that just takes the mental stress off of you. And you sit there and you learn the different things you don't see. You sit there and say, I'm lining up the heads. I know the incisions are placed, but I'm lining up the screw heads because I'm thinking about the rod. I'm not so much thinking about the screw placement because that's kind of automatic. But that's the exact example I was thinking that said that makes my life easier.
And final question to our illustrious Congress chair and newly minted deputy editor for Global Spine Journal. Very grateful for your help and vision. Talk about ethics of publications. So one of the studies shown in the earlier session on SI screws by Dr. Alves showed very openly how conflicted many of the studies are in terms of no companies mentioned here, certain manufacturers who highly target SI fixation. How critical should we review the robotics data when there's some studies or some claims out there that most of the authors right now have some industry conflicts? What can we do to kind of try to make this a little bit more transparent to the readers?
I think this is always a challenge that we have with any journal with the editorial board, right? Because nowadays you can see some of the papers are clearly mentioning the name of the robot that's being studied in the study. And I don't think we should shy away from that. We should, because we already know it's always very odd when you're talking about something, is that robot or that robot, and you're not mentioning by name in the study. And then I wonder at the end of the day whether the reader is getting any benefit from reading that study without mentioning the names of the products out there or the industry as well. But the more papers we have and the more meta-analysis that we're going to have later on, we can, if we have more data published, then we can sit and say, oh, this particular paper, the author had some relationship with the industry, then maybe I shouldn't pay much attention to that one. And maybe I should, take a look at another paper that doesn't have much of a relationship with the industry. But at this point, we don't have too much data to have that luxury to sit and say whether this is inflicted by industry or not. So I think it's a matter of time. If we're going to have more publications, then we're going to have sit and critique and say, well, this is industry funded. This is data that we shouldn't trust. And this is probably the data that is very valid. It's coming from a systematic review or a meta-analysis or a higher quality prospective study that can be of more benefit for sure.
With this, the session will come to a close. It's been a lively 1 hour, and we're so grateful to the excellent Congress organizers here at MENA to host our Global Spine Journal Club, a virtual live journal club. I would like to invite our 3 physically present young next stars to come up to the stage and receive the due applause for their great work and insights. And thank you all. Thank you very much. Dr. Elnaga, would you want to join us? Ex officio? No, okay. But thank you all for your attention and thank you for your support of the Spine Journal. And it's a great pleasure to work with this journal and to have such a global audience. And our president, Dr. Emmerich, is back here. Thank you so much for your support of this academic endeavor. Appreciate you all. Big of us. Yeah.